So I know you've met Dr. Tinkle and Dr. Mittal. We also have Mercedes. Mercedes is a trained physiotherapist, and Jaden is a patient with lived experience with hypermobility. I'm going to get their bios here. All right, so Jaden is completing her final year of her Bachelor of Education at the University of Calgary, and she also holds a Bachelor of Child Studies with a major in Child and Youth Care Counseling. She's worked to support students with complex medical needs inside the classroom, and she's currently engaged in research around Ehlers-Danlos and hypermobility as a knowledge user. And Mercedes is known for her hands-on and empathetic approach. She's worked very closely with hypermobile people to improve their quality of life. She's now working in a non-clinical capacity, but continues to provide cooperative approaches that empower both individuals and providers. So thank you all for coming. So some of these questions have been addressed already, but we'll start with a question for Mercedes and then also address the same question to Dr. Mittal. What exercises have you found are safe to do in hypermobility?
Yeah, thanks for the question. This is a question that we get from people of all walks of life, not just people with hypermobility, because anybody who's going to do exercise, of course, wants to do it safely. So safety for each individual is going to really vary. As we heard throughout the day here, everybody's zebra stripes are different. So everyone's going to have a different requirement for safety. That being said, the main things that tend to be safe are the ones that push your body a little bit. When we think about why we're doing exercise, it's because we have a goal. We want improvement in some form. And so if you push your body beyond its boundaries a lot, then that's when you're going to have potential safety issues, falls, dislocations, things like that. But when you find out where your body's at, and then you can make baby steps, that can help with the safety. And I find that a lot of the time, people with hypermobility or with EDS really just need to find out where their body's actually at, instead of comparing to non-hypermobile EDS or non-hypermobile individuals or kind of your textbook person. They need to find out where they're at so that they can take baby steps from there.
I would agree with everything Mercedes has mentioned, and each patient has a different severity of disease and symptoms that they have. So an individualized approach for safe exercises applies to everyone. Broadly, as I mentioned, the way we look at it from science and evidence, two different kind of activities. One is aerobic activity, the other one is strengthening activity. For aerobic activity, the goal is to get to 30 minutes 5 days a week. Now, not everybody can start 30 minutes, so you can start at 2 minutes, 3 minutes, 4 minutes, 5 minutes, whatever is convenient for you. You can start 5 minutes. Then again, you have to start with some horizontal exercises, because if you have concomitant orthostatic hypotension, and if you start with exercises standing, that may not work well for you. You might get fatigued even too early. The other principles are you can gently, as kind of Mercedes mentioned, take some baby steps every week. You can increase that 1 minute, that time by 1 minute, eventually trying to get to a place where you reach 30 minutes 5 days a week. Now, there was a question in the video chat before from the online group is if they have post-exertional malaise. So there would be some fatigue after you exercise, which happens with everybody. But the thumb rule which we use is if you are fatigued 24 hours after the exercise session, then you probably overdid that session. So you should reduce the intensity of the exercise, whichever exercise activity you were doing, but try to keep that duration consistent and do it 5 days a week. So that's broad principles for aerobic exercises. For strengthening exercises, you can start with 1 to 2 days a week. Again, horizontal-based exercises. Brad showed a great image why we suggest mid-functional range strengthening, because if the natural range of motion for hypermobile individuals is going to the end extensions, which predisposes them inherently for joint injuries, and there would be micro injuries or micro traumas that could accumulate. So we want them to not do the exercise in the end 10 degrees, kind of like range of motion. You do mid-functional range. You start with no free weights, probably should start those strengthening exercises under the supervision of a therapist or a trainer initially, and once you start feeling comfortable, then you can start increasing the range through which you work, or start incorporating free weights.
Thanks. Thank you.
Sorry, I'm just
Yep.
going to add, yeah, I think the person who asked this is probably looking for specifics in terms of recommendation, and it's hard to give a specific exercise that's going to be safe for everybody. But I find that a lot of us, before we start, jogging or doing links in the pool, we can benefit from something like breathing exercises. We've talked a lot about, using the abdomen to have to do with blood pressure and heart rate. And we've heard about pelvic floor and aerobic capacity. And so it can help to just practice breathing and take that diaphragm through its full range of motion instead of having it go on and off, and learning to control breathing. You can do it lying down, you can do it sitting, you can do it waiting for the bus. And so what I mean with baby steps is sometimes we start like, okay, I'm gonna start an exercise routine, but we can really back it up and take the time to do it progressively.
Thanks. The next question is for Dr. Tinkle. So as some of you might know, that there's been some recent research suggesting blood biomarker for HSD EDS coming out of Italy. How do you see research evolving into a way to diagnose or confirm hEDS? I know you touched a little bit about that, but did you have anything to add?
Yes, so I've seen the data. They tested several different kind of conditions. They found various overlapping biomarkers. Biomarkers are helpful, but you still need to be vetted out what is going to be useful, both for diagnosis and if you want to sort of measure in kind of severity or response to treatment and stuff. So I still look at it as a very early information. We've been looking for things like this, but I think we're just going to have to wait a number of years until it gets better vetted out, because I don't want to necessarily use it to make the diagnosis when we don't even know how sensitive it might be in comparison to ruling out, let's say, rheumatoid arthritis or some other condition. So I do think if it's going to be included, it's going to be included still with that clinical acumen, what this is, and this may be supportive information. And I even look at genetic testing that way too. You should never make a diagnosis without having some clinical presentation and say, oh, well, this is this. Because too many times it's just because we don't have enough information and we made the wrong assumption about the genetic tests.
Great. And just to follow up on that, and I know you talked a little bit about this in your talk, there was probably 12 or 14 questions related to the genetic diagnosis and that sort of thing. So people are really curious, is it necessary to get genetic testing? When is it indicated if they only have hypermobility?
So currently there isn't a genetic test for the hypermobile form of EDS. There's been 2 genes most recently floated out there. It is, again, nothing that has been really reliable, and so we're not really using them in part of the clinical arena. I personally do not test my patients. If there's something about them that's different than what I expect from a hypermobile patient, then that puts a flag in my head, and I may test them for that. It could be a family history of aneurysms or uterine rupture or something like that. That's just not typical. Then I will test to rule out the other forms. I have the luxury of doing this for 20 years and seeing thousands and thousands of patients. So I feel pretty comfortable in my skin. With that said, the other people who sort of do this and may not see as many patients, if they want to test, I'm not saying that that's wrong, but it's just one of the things I do not do because I feel very comfortable in what I can do with it. Most of the other forms of EDS are fairly easy to recognize, and so I feel comfortable doing it. But not everybody does, and if they want to rely on the genetic test to rule out some of those other forms, I don't have much qualms about that. But I do get kind of asked this question, should I have genetic testing? To me, it's one of those questions. If you want a peace of mind, that's fine. If the doctor wants to do it because they want to rule out other things, that can be fine. But I will tell you, in my experience, a lot of these tests don't come back positive or negative, they come back with an I don't know. And I've had plenty of horror stories about an I don't know. Because let's say most time we don't just test for EDS, we test for connective tissue diseases, and someone comes back, oh, well, I had a change in the Marfan gene, so I must have Marfan. It's like, you don't look anything like Marfan, you don't have the problems of Marfan, you don't have it. But yet the next thing they do is they tell people they have Marfan and their treatment goes a whole different route. What we do in Marfan is lower their blood pressure. That one obviously would not be a great thing for people with POTS. So that's the reason why you need to look at genetic testing as part of the puzzle, and it needs to be put together along with the clinical medical history and making sure that it makes sense for you.
Thanks. For Jaden, again, not everyone in the audience is a patient. So how has having hypermobility affected your quality of life? And as a second part, did having a specific label change things for you?
Yeah, so having EDS and specifically having hypermobile EDS definitely has had a huge impact on my quality of life because I grew up as a competitive cheerleader and a competitive figure skater. So I was like touted as like, oh my gosh, being flexible is the best thing in the world. I had like an oversplit. So for those of you who don't know, like you have your splits here on the ground and then your top leg is like above. So I had like all the tips and tricks. I was the contortionist that was mentioned earlier, and it was the best thing in the world. And I grew up in a family of people that were undiagnosed with hEDS. And so no one put it together. And I also had I remember I was telling someone about this earlier. My mom looked over at my file at the doctor one day and she's like, oh, why is this all highlighted? And they're like, oh, well, we're investigating you for child abuse. Because I had so many injuries that weren't explained and so many joint dislocations and subluxations. And I was always covered in bruises because I was so active. And then when I was 12, I had a partial ACL tear that I just remember the doctor was like, oh, well, it's growing pains. And so for half a decade, I was in chronic pain for a partial ACL tear. And they were like, it's fine. There's nothing going on. And so it was really frustrating to like walk through life not knowing what's going on, to have all these constant joint injuries. And then when I was 19 or 18, someone finally was like, hey, I don't think this hypermobility is normal. I was hospitalized for like other health issues that were related to dysautonomia. And so having a diagnosis, I had already experienced so much medical gaslighting. And I was like, wow, I'm not crazy. And that was this moment where I was like, I'm not crazy. This is like, actually something is wrong. And all these things aren't normal. So it was like this full circle moment. And since then it was just being able to like learn the skills of how to advocate for myself, how to advocate for people with EDS as well, has been really significant and just like allowed things to click and make sense. Yeah.
Really validated what you were going through, it sounds like. Thanks. We had a few questions around exercise, but also around sports. So maybe for Dr. Mittal, is it safe to do sports when you have hypermobility?
It depends on what kind of sport are you planning. If you're planning to do like a high contact sport, then probably it's not a good deal. Again, that question is asked often by patients, who like doing different kind of sports recreationally or competitively. And again, it's a very individualistic answer depending on how hypermobile their joints are and also what kind of Ehlers-Danlos syndrome they have. Like sports is looks so much different for vascular EDS versus what it looks for hypermobile EDS or a generalized hypermobility spectrum disorder patient. Ideally, it's a definite no-no to any contact sport. But if you really like, playing tennis recreationally or golf, or for that matter, any other sport, and if you need to identify the triggers which cause those injuries, and then probably before you return to that, you need to engage in a specific rehab exercise program to be able to make sure that you mitigate the risk of those injuries. Again, people who don't have EDS also get injuries while they play sports. So there's always that mix in terms of how safe you want to be versus if you really want to give up what you love in your life. So there's always that balance every individual has to find.
Thanks. And a few people asked questions about like how we could make accommodations for people who are school age or university age in terms of physical education. Any general recommendations? Like in terms of kids going to school, or Dr. Tinkle, if you wanted to add something?
So it kind of goes back to what you commented about activities and et cetera, learning the activities. Unfortunately, in most physical education classes, you're kind of pushed to do things, and it may not be comfortable. You may not want to have a voice to say this hurts, and et cetera. So I use a lot of what's the capability of the student. Can we modify anything? In my experience, a lot of times it's really hard to modify things because they'll give me this list that tends to be ridiculous. Can I play basketball? And it's like, what do you mean by basketball? Are you talking about throwing down and running over each other and stuff like that? Or are you talking about shooting a basket in a hoop? And so it is one of those things that sometimes it's just hard to educate the teachers enough. And if the child does not have a voice, which is pretty common, then a lot of times they get bullied into things, and that's where they get hurt. And so a lot of times, what we'll do is we'll take a program from our physical therapist, and that is their gym class. So that's how we do a lot of the modifications around gym class, where they're spending time that's useful. They're getting kind of a physical fitness part of it, but they're also completing their work, because a lot of times the school kids are like, well, I'm busy with choir, I'm busy with this, I'm busy with that, I don't have time to do my exercises. Now you have time. And so that's probably my more successful program. But I do have, especially my males who just really want to be in the sports and look like a sports hero in a lot of different things. So again, everything's very individualized. But I try to control that as much as I can so my students don't end up with a tear or something that needs a surgery or whatever else. The other hard thing is about when you try to say, okay, you can't play this sport, my students would then sit on the side and all the other students would see that. And then there's that social pariah kind of thing. And so I don't like that to do either, because again, mind and body affect physicality and vice versa. So it is one of those things, again, everything's very individualized. We try to work with the schools, but if I have to try to override the schools, then I'll do that by making sure they're doing their physical therapy program outside and not doing gym.
Thanks. Yeah, and I know earlier people had asked about resources. So the Ehlers-Danlos Society does have some resources in terms of things you could give other clinicians or teachers when it comes to some of this stuff. So that's another resource you can check out. So we've talked a lot today about how a lot of managing hypermobility is learning how to self-manage, self-advocate. So a few people asked, and I'll ask this question to you, Jaden, and then Mercedes, say that I have a joint subluxation. Any tips and tricks for managing that on my own at home?
In my experience, having a good relationship like with my physiotherapy or my physiotherapist, so then like that has been the most helpful because to prevent them. But then if it's a joint that like I repeatedly have like a dislocation or a subluxation in, I usually feel comfortable managing it, especially like smaller joints. But that's just like, it really depends on your own comfort. And then, but yeah, having a good relationship with a practitioner and then developing a program with them. But then and this is like my own personal, do not, if something is like new, really uncomfortable, really, really painful, I will tend to err on the side of caution and seek like medical help. And just because like the risk of joint injury, because I'm like, oh, I can handle this, I can deal with it, for like an acute dislocation becoming a chronic injury. Because I think that's something a lot of patients with EDS have experienced, where they're like, oh, it's just like one small thing, and then it turns into a really big thing, which mentally is like really frustrating and really exhausting. But yeah, to me, the basis of it is having a good relationship with like a physiotherapist or like a healthcare practitioner, and like figuring that out for yourself, which isn't a great answer, but.
That is a great answer. Thank you. Anything to add, Mercedes?
Yeah, so I would be that health practitioner on the other side of things. And Yeah, I want to make a distinction between subluxation and dislocation. So subluxation being a shift in the joint, it doesn't come all the way out of the joint versus a dislocation that comes all the way out. So when you're managing subluxations on your own and your joints shift, prevention is the biggest thing. Once it happens, obviously you can't prevent it, but we heard this morning about muscles providing stiffness for a joint. Oftentimes when people sublux at home, it'll be when they're not paying attention or when they're sleeping, when their muscles aren't activated. And so that passive stiffness can help. So strengthening muscles around the joints, especially those small joints, right? Like in your hands, doing those fine motor exercises and getting those muscles strong around the joints. And then if you find that you're subluxing a lot at night, that's where pillows and positioning and braces can help.
Fantastic, thank you. And we've touched a little bit on it today, Dr. Tinkle, but could you maybe discuss a bit more if we know why there's an association between hypermobility and neurodivergence, or hypermobility and mast cell activation syndrome? We had a lot of questions about those two things.
So neurodivergence and autism. There has been a long history that kids with autism have a tendency to have low muscle tone, which can contribute to excessive joint mobility as well. And so we've known that for a long time. I do have a good number of my patients with an autism diagnosis. In the US, it's estimated about 3.5%. My number is closer to 5%. So, but I also treat all comers with hypermobility. I don't necessarily discriminate, oh, you have EDS or you have hypermobile spectrum, because if they have hypermobility and they're having issues related to it, that's where my experience hopefully can help them, and that's what I should be doing. So I don't think there is a true increase really in the autism in the neurodivergence in that population. I get asked about it a lot. Because I can look at it from thousands of patients, and I just took 6 months worth of data that I just mentioned to you, that I don't feel like it is. My partner, who's the other half of my program, that's all he does. And we don't see a lot of overlap between our patient population. But clearly, if there's some hypermobility issues or low tone issues, sometimes I'm helping him with musculoskeletal concerns in that population. As far as mast cell stuff, traditionally mast cell has always been estimated to be close to the most concrete number I saw was 17%. That means a lot. And it, just like everything else, there's severities of it and et cetera. How I got introduced to mast cells was almost 20 years ago. Vanderbilt studies of that, hey, if you can't take care of the POTS, if it's not responding, you need to be thinking about mast cell stuff. And so we started asking some of the stuff, and most people had, well, I have allergies or whatever else, but they didn't necessarily have the rashes or some of the true sensitivities that others would have. There's still a good number of my patients that have mast cell stuff. It is beneficial definitely for the POTS to sort of treat the mast cell stuff. But I'm a little reticent to sort of believe some of the mast cell experts that says it's pain, it's this, and this, because in my population, quote, with mast cell and my population without mast cell, they don't look too much different. But it is something that's a significant comorbidity. I do think it needs to be treated appropriately. I will dabble. I will start kind of like the first tier antihistamines and et cetera. But I've been fortunate to identify some allergy immunology people that I like to send people to. But the most common sense about the diagnosis I like, because I try to be more common sense. My wife may not agree I have common sense, but it's one of those things where the laboratory stuff, we heard about tryptase earlier, most time is not either available, or in my institution, it's done wrong. And so a lot of times if I go send them for it, I get like 0 tryptase, and it's because they didn't handle the specimen correctly. But the other two parts of that is, do they have like the rashes and the itching, and do they respond to antihistamines? if the answer is yes to that question, you're supposed to have mast cell. And if that helps my patient, I'm all for it. So I don't necessarily feel there's a strong link that others feel, that they call the trifecta and et cetera. But again, I'm looking at it from perspective of thousands of patients that I know sometimes when people plan 40, they go, oh, the mast cell's in this number, and they get more excited about it. So I look at it differently. It's one of those things, prove me wrong if that's the case, but as long as I can treat it appropriately and et cetera. The thing that I only am not so sure is how much of the GI disturbance is mast cell stuff. And that's, again, where it's nice to have an allergist immunologist who will look at that and decide whether or not some of their GI symptoms are mast cell related.
Thanks. And Dr. Mittal, I think you wanted to add something.
Yeah, I'm gonna just present a slightly different viewpoint on that. The way we look at it, mast cells now, mast cells are part of a natural immunological process, and what the research has now shown is that there's an inappropriate response of mast cells which happens in certain conditions. Now, previously, hypermobility is related with some mast cell inappropriate activation or mast cell activation disorder. However, hypermobility is also not exclusive to Ehlers-Danlos syndrome. Hypermobility is found in more than 1,800 medical conditions if you look at like some of the databases. So the question then becomes if they have mast cell activation disorder with associated hypermobility, is this because of Ehlers-Danlos syndrome, or is it because of an alternate disorder? In the last 5-6 years, there's a few other disorders which have come out. One of them is hereditary alpha-tryptophanemia. We have seen in some of our patients who had hypermobility and who had a severe kind of like allergic manifestations, but they did not have any skin features or any other fragility events, and a bunch of dysautonomia as well. And they got tested through the immunologist for hereditary alpha-tryptophanemia, and that came back as positive, that genetic mutation. So then it helps us identify whether their mast cell disorder is related to Ehlers-Danlos syndrome or not. There's still, like as Brad said, we don't know if it is truly like, if there's a higher association specifically from a hEDS standpoint versus it is just part of a confluence of different factors like dysautonomia, which then triggers the mast cell and causes some of the allergic reactions and also contribute to chronic pain. There's some research which has also looked into some of the fragments of collagen in the skin around the microglia where the mast cells are located, and they're deficient in people with Ehlers-Danlos syndrome. And that could cause some of the chronic pain and other stuff. But it is all very primitive research. And again, the point being is mast cells are associated with inflammatory immunological disorders. One other point I'll make here, though, is that the study about the plasma biomarker from Italy, which came out, that actually and I was actually one of the reviewers of that study before it got published, and they had a very very homogeneous database. They looked at more than 450 patients, and they had people who had HSD, hEDS, they had classical EDS, they had rheumatoid arthritis, psoriatic arthritis, and healthy controls. So they covered a bunch of immunological inflammatory disorders along with it, and they found a very specific fibronectin component of a 52 kilodalton fragment, which was only found in people who had HSD and hEDS. And if that study holds value, and there's other studies now going on trying to reproduce those results and see if it is true or not, then it might lead actually more into insights into whether some hypermobility or HSD is a part of an inflammatory immunological disorder, not truly a genetic condition, because mind you, we've not been able to find a monogene for hypermobile EDS. So that is some other consideration that is kind of like going on.
Perfect. Thank you. Well, that's all the time we have for our panelists, so thank you very much. Dr. Tinkle, I'd sent him all the questions that I thought would be relevant to him, and he sent some answers back for all of the questions that we didn't ask today, so those will be sent as well this week to everyone who's attended. I'll quickly wrap up because I know that we're getting close to time. So I really want to make sure that we acknowledge that this event couldn't have happened without some great sponsorship, particularly from the Canorector Foundation and from the McCaig Institute, but as well as our other partners. So please, if you have any connections with any of these folks, please thank them on our behalf. As I mentioned, we had a lot of support from our knowledge user team, a lot of volunteers here, so please thank them. They've given up their Saturday and many hours in the months leading up to this to plan this. And a very special thank you to all of our speakers and panelists as well. We do encourage you to reach out if you have feedback, suggestions. We'll send the survey shortly, but this is our lab's contact information. If you have research ideas or want to be a patient partner with any of our studies, our patient partners just help to inform that we're doing our research in an ethical way. We're getting our results out to the people that need to get those results. And just a reminder again that in order to keep advancing this, we really need your help, whether you're a clinician, patient, family member, researcher. We all need to work together to really make things better for people here in Alberta. So here's the survey. Please use the QR code, fill it out. If you forget, we'll be emailing it later this afternoon. And like I mentioned, we'll keep the doors open here till about 2 if anyone wants to interact with each other. Our speakers will stick around as well if you didn't get a chance to ask your questions. Thanks, everyone.